Good day, and thank you for joining us for Outlook, Artificial Intelligence and Managing Chronic Disease. I'm Karen Drexler, a serial medtech entrepreneur. Most of my experience is in diabetes, women's health, and respiratory. I'll be moderating and also participating in this discussion. We have a panel of leading experts in autonomous insulin management, telehealth, and the rapidly evolving digital therapeutics landscape. You can read our bios on the left side of your window by selecting the Speakers tab. Let's meet the others. Aran Bashan is CEO of Hygieia, an innovator in the digital therapeutic space and co-developer of the AI-driven insulin management technology called d-Nav.
Hi, everybody. It's a pleasure to be here with you today.
Karen Kopilov is a partner at First Time Ventures, which funds cutting-edge healthcare technologies that are increasing access to care.
Hi, everyone. Good afternoon.
And finally, as a note, Mark Hirschhorn sends his apologies for not being able to participate today. He provided us with his insights, with some content about telehealth, the complexity of data, mental health, and how AI can support the healthcare system. So we'll be representing his positions as well. Just a few technical notes before we begin. The webcast is being streamed through the computer, so there's no dial-in number. For best audio, please make sure your volume is turned up. The webinar is being recorded and will be available on demand in about 24 hours. Time permitting, we'll follow the presentation with some Q&A. Please submit your questions in the questions and answers section on the left side of your screen. Now let's get started. So COVID has accelerated an adoption of virtual care. If you look at this slide in front of you, you can see on the right side, Medicare visits increased 63-fold from 2019 to 2020 as people needed to rely on virtual care. And as that was happening, you can also see that U.S. funding went through the roof. So this is funding in digital health ventures. And what was going on here? It's not that technology wasn't available. So technology to allow us to do virtual care had been around for quite some time, but there were a number of obstacles that were in our way. Economics, there was little to no reimbursement for doctors to treat patients remotely. And there was so much complexity with different states, different licensing that it made it hard to access providers. Once COVID hit and facilities were shut down and healthcare professionals were diverted to caring for the very sick, there was a massive demand for remote care. And because of this, there was some immediate action that was taken. CMS suspended state-specific requirements that made people operate only in the state that they were licensed. So basically a practitioner in the US could operate across the 50 states. We also saw funding, reimbursement for remote visits, basically match that of in-person visits. And these two things together dramatically accelerated adoption. So overnight, every provider could be a remote care provider, and companies like Teladoc, Amwell, and MD Live had infrastructure already that they could provide to make this happen. So when we look at technologies that allowed this to happen, AI was among the most promising. So let's start with what is AI and how is it being used in healthcare today? Aran?
Thank you, Karen. So there's a lot of notion of what AI is, but in the most basic sense, it is now defined as technology or software or intelligence demonstrated by a machine, which perceive its information and take actions to promote a certain goal. More loosely speaking, these are computers that are doing something that people used to do or usually do. A most common example that many of us use on a daily basis is navigation apps. And we probably still remember the days of the Garmin GPS that would sit in your car and basically monitor your progress against a pre-calculated track. And when we missed a turn, it would be kind enough to tell us, I've noticed you've missed the turn, but don't worry, I'm recalculating the route and I'll get you going soon on a better track. Next generation of navigation apps, now systems like Waze or Google Maps are using traffic information. And they have access to information that we don't have to tell us, well, there's some kind of a delay up the road. I'm going to reroute you to avoid this delay so that you're going to get faster to where you're trying to go. And as we progress with the technology, we're now seeing more and more such tools being used in healthcare.
Great, thank you. And we already touched on this earlier, looking at the incredible growth of remote healthcare and the use of digital health tools during the pandemic. And here's another way of looking at this. You can look at the share of outpatient visits delivered by telehealth. And you can see that until the pandemic, until March of 2020, there basically was no usage. And this relates to some of the obstacles that I mentioned earlier, with a big spike happening when medical offices shut down in the early part of 2020. What's interesting is that the adoption was even greater in the areas of mental health and substance abuse. So what role did AI play in being able to get these incredible numbers of telehealth visits delivered using technology? Well, basically, AI was employed at the front end of the patient experience to triage patients. We could use AI to look at what the most likely condition is that the patient is experiencing. What's the most likely treatment plan? What clinician is best suited to this particular patient? And that's important because with clinicians, again, focused on the pandemic, for those things that could be supported by a nurse practitioner or a physician's assistant, you'd rather have those patients in touch with those healthcare professionals and save the doctors and particularly the specialists for the visits that needed it. In mental health, it's a little more complicated. So often diagnosing mental health conditions is difficult. So using AI with a set of prescriptive questions allows the doctors to have a most likely list of conditions from which the patient is suffering. And this helps reduce diagnostic time, removes subjectivity and bias, and human error, and again, allowed us to treat the incredible spike of patients who needed to access this remotely. And in the mental health space, after diagnosis, AI can also be used to help prompt the providers in terms of follow-up for patients, as many of these patients need to be seen frequently on a weekly or even more often visit, and also to identify and make sure the patient is on the most practical treatment strategy to lead to remission, better outcomes by looking at what's worked with similar cases. So huge use of AI to make sure we could just deliver the care that was necessary. Karen, could you talk about some of the applications that you're seeing at First Time, what's evolving in this category?
Yeah, sure, Karen. So First Time has invested since its inception in 2014 in where digital change has taken place. Our focus is investing in companies and assisting them with their digital transformation. AI and the digital change began in areas such as media, advertising, retail, continued in telecom and insurance, in banking, and through consumer goods, disrupted automotive and logistics. And in recent years, it has also been disrupting the healthcare, a process that was accelerated in the last 2 years. A main change that we are seeing is that patients are now consumers. They are taking responsibility for their own health. They are deciding what's best for them, what to use and what not to use. They demand convenience, they demand transparency, and exactly like in other sectors, it's all about patient experience. So in this slide, you can actually see the evolution of an insulin pumps from the 70s and until today. So the pump started in the 70s as a very huge and heavy instrument that had to be carried like a bag. And it went a long way until today. In the 90s, we were introduced to small, compact, and effective smart pumps that had, new features like alarms and bolus calculators. Then came the patch pumps that are free of insulin sets. They're small, light, and allow flexibility to the users. And later on, Minibed introduced sensor-augmented pumps that used CGMs and developed feature that suspended insulin delivery when sensor glucose level hit a low threshold. This was a major step towards a closed-loop system, or the artificial pancreas system, which is a combination of progressive technologies. first the sensor like CGM that measure blood glucose and sends data to the computer algorithm. The algorithm analyzes the data and sets insulin doses, and this insulin pump that delivers the insulin per the algorithm instructions. So AI plays a very important role in care of people with diabetes, and the need in closed-loop system urge people to use do-it-yourself systems rather than wait for the mainstream technologies that had to get regulatory approvals. So it's a very good example for patients taking their health to their own hands and causing market shifts.
It's a great example. Some of what we talked about earlier in terms of triaging visits and finding the right provider, some of that relates to acute conditions. But as Karen mentioned, there's a huge need in the chronic disease management space. So let's talk a bit about the complexity of managing patients with chronic disease. Iran, Hygieia has been treating patients for over 10 years, patients with type 2 diabetes. Can you talk a bit about what makes caring for these patients so complex?
Yes, so I think there are a few factors that are working together here. The first thing is demographics. As we know, we have aging population. Today in the US, there are 72 million people that are 60 years or older. And as we live longer, we develop more and more chronic conditions. So 6 out of 10 people in the US have a chronic condition, and 2/3 of them have more than one chronic condition. So you could have diabetes and hypertension and depression. And when we typically talk about a certain condition, we think about it as an individual condition, not connected to all of the other conditions that you have together. So the second thing that's in play here is if you look at the evolution of treatments. So this slide shows the number of approved drugs by the FDA over time. And the left side of here starts before World War II, we had 5 drugs on the market. Today, there are over 1,500 drugs on the market, and there's just so many more options that we can use to treat a patient. And if we look at diabetes as just one example, so this is the standard of care by the American Diabetes Association for diabetes, and I don't want you to try and read this slide. This is going to be hard and painful, but it just shows you of how many options we have today to treat somebody with diabetes. So we have 7 different classes of medication. And if you look at a medication class like insulin, there are more than 50 different types of insulin on the market. And when you have a patient that's taking other drugs, the choices are not always clear. Just on a personal note, my father-in-law came to me a few weeks ago and said that his sugar have started to go up. And he's 86 years old and he had diabetes for 20 years. And he went to see one doctor, and the doctor suggests to switch here from the orange to the red. And then he went to see his primary care physician, and the primary care physician say, I don't agree with the cardiologist. And then he called me and asked, what should he do? And I reminded him, I'm not a physician, but I suggested he go and see an endocrinologist. And the endocrinologist went back and said, yeah, I agree with the cardiologist. And now you could do majority voting. But the idea is that it's not that one physician is wrong and the other one is right. They're just looking at a complex condition, and the answer is unfortunately not always clear.
Yeah, definitely lots of complexities.
I'm just jumping here to tell you around that, as you know, that as you mentioned, and drug-related problems, they cause, they are one of the leading causes of mortality. And I am familiar with a few startups that are, dealing with this problem and using data-driven technologies to optimize medication and solve the drug-related problems. So they collect data of clinical status, genetic data, the labs results, and they offer, decision support system that helps manage medication regimes and patient safety. So just a note about that.
Which is hugely important. And just starting from the bottom of this slide, the more drugs you prescribe, the more chances that you're going to have interferences, complications from one drug that leads to side effects that need to be managed with another drug. So it only gets more and more complex. We look at the population, and we now have 80% of patients who have a physical chronic condition actually have more than one condition. And there may be behavioral conditions that are added on top of that. So think about how complex that is for an individual physician to try to handle. When you have multiple conditions and you're looking to diagnose something new, there also is a lot of complexity because you don't know if you're seeing a symptom or a side effect of something else they're already doing, or you're seeing something new. And in fact, in more than a third of the patients who present with multiple chronic conditions, the initial diagnosis or suggested therapy can be wrong, or it can be incomplete. And these are all areas in which AI can help us. They can help make sure that physicians are aware of the treatment options for this range of conditions and help reduce errors. So it's a really important area for us to be using artificial intelligence. I'll also note that payment models in the US are shifting, although slowly, because we've been talking about this shift for a long time. We are moving in some cases to value-based payments, to risk-based payments, where the rewards are optimized around better population management. And physician income is tied to how well their patient populations do. So this is an area in which health systems and physicians are looking for tools to help them, because in many of these complex conditions, they just don't know what they can do on their own to improve the outcomes for their patients. But they're being measured on these factors, and AI can help provide the right tools to help them meet these goals. So there are many, many opportunities for AI in healthcare, particularly in managing this chronic care setting. Aran, can you speak to some of this?
Yeah, so here's an interesting slide. This is the number of weekly telemedicine claims over time, comparing 2018 and 2019 in blue and red to 2020 in orange. And this dotted vertical line marks March 10, which, as we may recall, is right around where COVID started to become apparent issue in the US. And more importantly, after March 10, Independent Blue Cross announced that it would start reimbursement telehealth visits. And with that, opened the floodgate pretty much to every payer in the country to follow suit. And within 4 weeks, we had 70,000 visits a week. And we needed to manage all of that because at the end of it all, as we'll see later in the presentation, there's a big shortage of providers. And we used technology very quickly. Companies like Teladoc, like American Wealth, like MD Live that already had infrastructure in place. And suddenly, with the removal of the restriction you mentioned before, Karen, of state line restrictions, there was an infrastructure over which all of this care could have been delivered. So we've used the AI infrastructure to route all this tremendous demand that suddenly fell on the system to take advantage of the limited resources that we have and address all these visits.
Not easy. And what we can see here, obviously, is the virtual visits have declined some from their peak. Right at the peak of the pandemic, individual doctors' offices were often not open, so patients had no other choice. And in some cases, patients do want the flexibility of going in and seeing their doctors in person. But the levels have remained high, and the belief is that they certainly will, that remote healthcare, providing remote healthcare, is a permanent part of our landscape now. And it'll remain a cornerstone, in part because of convenience. Karen mentioned how important consumer-driven healthcare is. Consumers want convenience, they expect good outcomes. And for some patients, this is the best way for them to receive care. Karen, can you talk about some of the other trends you're seeing in both the research area and the funding area relative to AI?
Yeah, so you both talked about the burden and the high costs of chronic conditions on the healthcare system. We can certainly see technologies that detect, monitor, and treat chronic conditions as leading funded sectors. As you can see here, in the first quarter of this year, monitoring and treatment of chronic diseases were in top funded value propositions, increasing to 30% out of total funding. And also, 4 out of the 6 new unicorns born in the first quarter deal with monitoring and treatment of chronic diseases, such as diabetes, cancer, kidney disease, like Somatus, that identifies patients at risk of chronic kidney disease and prevents progression by early intervention. Another example is Atlas, that brings the labs home, and it developed a blood diagnostic device that monitors blood pressure, glucose, weight, and medication, and it analyzes the blood sample with AI technology and provides the metrics to the physicians. You can see Omada Health, that helps people in managing their own health condition through personalized data-driven behavior change coaching. There is Concerted AI that offers healthcare data products to providers or organizations that are seeking to improve patient experience, and they are focusing on oncology. So we can see that startups focusing on monitoring, prevention, detection, and treatment, they get a lot of attention from investors and the healthcare ecosystem. We in First Time also focus on technologies for predictive health, remote monitoring, early diagnosis, and at-home treatment. And we recently invested in FeelBetter, which is an example of one of our investments. It's an AI platform that tracks patients with one or more chronic diseases that are in risk. It identifies the risks and it recommends on precise medicine in order to prevent disease progressions and hospital admissions. And it improves, of course, clinical outcomes, but also financial outcomes for organizations. Another sector that is very important to me personally as a woman is the femtech. We see more and more women entrepreneurs that are seeking for solutions for early diagnosis and detections of women's chronic conditions. And we're also looking at technologies that come to solve increasing problems, like, for instance, infertility. So to summarize here, we can see that the use of AI is in every aspect and field of digital health, and it touches everything we do. And there is a huge need for improving accuracy, quality of treatment, and safety. As a result, demand of AI in healthcare solutions is increasing constantly. It is estimated in $6 billion and growing very rapidly, estimated to be $95 billion within a few years.
Thank you. You've been talking about the money coming in and some of the technology. This is another way we can look at the market and how it's grown. Remote physiological monitoring, being able to do things like measuring your glucose at home, is actually covered now under separate codes that were put in place rather recently. And with this recent shift, Hygieia, as an example, moved from a platform where there were in-office visits to a fully online and digital platform using these kinds of codes to cover visits and cover treating patients. But this slide I find particularly interesting because there was a survey that was done in the early part of 2020 projecting how the use of these remote physiological monitoring, not just the codes, but people's use of technology to monitor themselves at home. And this could include things like taking an EKG with your Apple Watch, for example, but looking at the number of patients that were predicted to use remote physiological monitoring. So the blue line shows the projection that was done in August of 2020. So this is 2/3 of the way through the year. And there was a projection of not only 2020, but how this would grow over the course of the coming 4 years following. By the end of 2020, if you look at the forecast in orange that was done just a year later, that included actuals for 2020, you can see that the actual usage of remote physiological monitoring exceeded or basically matched the projection that had been done just a few months earlier of what would happen over the coming 4 years. So patients, consumers have really jumped on this trend, and you can see how rapidly now this is expected to accelerate. So there are many, many metrics that we can see the value of remote monitoring, and this is being adopted by patients, by physicians. It's also driven by payment. So as I mentioned earlier, there are now separate codes that can be used for billing for companies that help doctors look at the data that's generated remotely by devices that are in the hands of patients. That's part of the whole ecosystem here that allows for this technology to be embraced. It allows for this technology to be funded, because without a clear path for payment, these companies are not going to see funding coming into the company. So a lot of really interesting dynamics in this slide, in this system.
And I
Okay.
think, Karen, one of the interesting parts here is that, and it goes back to something Karen said before about consumerism and consumer focus, this slew of devices that monitor physiological parameters, starting going back to things like Fitbit, a decade ago or so, were around, and people were using them more and more. But COVID forced also a shift in the way physicians are thinking. And now that they have to see us remotely, maybe we can take advantage of some of these tools that already existed and people are using, and try to figure out how we can make sense of it. And through this experience of the lockdown and offices being closed and the necessity to treat patients remotely, some of the physicians' thinkings about what can be done remotely have changed significantly just based on that experience.
Absolutely. And speaking of experiences, Karen, I believe you've got a very personal experience to share with us about how AI can be used to manage chronic care.
Yeah. So, in addition of being an eager investor in this field, I'm also a mom for a child with type 1 diabetes, and I chair the Israeli branch of Juvenile Diabetes Research Foundation, the JDRF. And my daughter, Daniela, you can see on the left, she was 2 years old when she was diagnosed with type 1 diabetes. And back then, more than 10 years ago, the CGMs were not very precise. And we had to do blood checks through finger pricks at least 12 times a day in order to monitor her glucose level. The burden was enormous, and we needed very tight supervision in order to prevent hypoglycemia events. And since she was diagnosed until recently, we haven't slept a full night. And we never left her alone, at nights without one of us being there. So during the years, it's only been 10 years, but the technology, has improved significantly. CGMs improved, and then we connected to the CGM, and we're getting a lot of data. And I have a friend that is serving with me on the board of the JDRF that he has diabetes for about 50 years. He was diagnosed when he was a child. And he told me, I feel for you, the parents of today, because when I was a child, my parents didn't know what were my glucose levels. We went to take a weekly blood test in the lab, and and they just watched my diet, and I guess my glycemic control was not very good, and was actually not as good as today. But my parents, they lived in peace. They had nothing to do. They watched my diet. And these days you get so much information and data that I don't know how you are not worn out. And he was right. People today, they get so much data from devices and from wearables that can cause data fatigue. I know it from a personal experience. So there are people that download the CGM data and analyze the trends and causes, but most of the people don't know how to use it. They don't know how to access to the data, and not to talk about, older people. So the significant improvement started a few months ago for us when we started using the closed loop system that I mentioned earlier. So the algorithm is now managing Daniela's diabetes. It's not perfect, and I think it has a long way to go, but it's still, it's a life changer for us. The closed loop has gained her trust, and it took the burden off her shoulders. And this, together with the improvement in the clinical results, motivated her to manage her diabetes. You can see here in the slide, this is data from Daniela's reports. As you can see, time in range increased by 79%, from 38% to 68%. This is huge, huge, huge improvement. And the A1C went down by 1 point. And for me as a parent, the mental aspect is even more important than the physical one, and the clinical one, because people that suffer from chronic disease, they have to manage it every day, 24/7, and it's very hard. And when the AI took a huge burden off their shoulders, it really improved the clinical outcomes as well. So thank you for letting me share my experience. And that's my story.
Well, I really appreciate it. Thank you so much.
So just to help add a little bit of a technical note here to Karen's story, what you see in this slide on the top is data from a continuous glucose monitor over the last 2 weeks period, over the hours of the day. And the white line in the middle is kind of like your average sugar. And when we think about closing the loop, what we really do is we need to adjust the rate of insulin infusion on a pump. And on the bottom right panel here, you can see the infusion rate of basal insulin in a pump setting starting up at one level, then kind of like around 4 a.m. drops a little bit to accommodate that drop in the glucose level that you see above right before 6 a.m. And then it goes up again and goes down towards the night. But the challenge here is not the average glucose, it's actually the spread represented in light orange here. Because as we know, the average day doesn't exist. Every day looks different. And you have to do that every 5 minutes. So that's simply not possible for a human to do. And that's the advantage that the artificial intelligence technology brought into Karen's daughter's life and to many other users. Now, the same thing is true for people that inject insulin. So insulin is a treatment that constantly needs to be adjusted. And that's what we brought in at Hygieia with our product d-Nav that provides the equivalent type of solution for people that manually inject insulin. So what we see here in this graph is, again, one patient example. The red line marks total daily dose of insulin. How much insulin does the patient inject in every given day over a 4.5-year period? And you can see here that the total amount of insulin ranges between about 95 units a day and 190 units a day, and anywhere in between. On average, every 6 days, there's an adjustment here, which is not surprising if you look at the data that came out from the manufacturers of the drug, like Eli Lilly or Novo Nordisk, that will essentially tell you need to go and see a doctor every week so that they can adjust your doses. So over this 4.5 years here, there are 280 adjustments of the treatment plan, all of them done by the d-Nav artificial intelligence. Now imagine if you were a doctor and you needed to see your patients once a week, even remotely, to adjust their doses. If you are seeing 20 patients a day, you can only see 100 patients a week. And if you need to see the same patients next week, that's as many patients as you can see. And without the use of technology like a closed loop system, like d-Nav, scaling insulin management to reach 8 or 10 million people that inject insulin in the US is simply not possible.
Exactly, which is why we need to talk about solutions that allow us to scale, given the chronic disease burden that we have here in the US. So if you think about our population, we currently have over 72 million people who are age 60 or older. And we've got demands of an aging population, growing rates of depression, and diabetes and other chronic conditions, which all are putting a strain on our healthcare system. Aran showed a slide earlier talking about the increase in the availability of drugs, of pharmacology to be able to use to treat these different conditions. If you look just over the last 20 years, we've seen a threefold increase in the number of older adults who are taking 5 drugs or more. And again, back to something we said earlier, these drugs are powerful drugs. It's likely these drugs will produce side effects, will interact with each other. This is not 5 standalone profiles to look at, but a very complicated picture. And looking at the other side of the equation, people who are not taking drugs at all in the older population, it declined from about a quarter down to less than 10%. So majority of patients are taking something, and many patients are taking many different drugs. So this all adds to complexity, and yet the people that we have to take care of our population are on the decline. If you look at the physicians that we have now versus the projected demand, looking at the shortfall in having physicians available, this is US market data in particular, we already know that there are areas of the US that are considered medical deserts, where people have to drive a long way to see a physician of any sort. But when you look at these numbers, it's pretty staggering. We're projecting up to 50,000 shortage over the next 50,000 physician shortage over the next decade or so for primary care, and as many as 85,000 shortage in specialty care. So how do we combine this huge increase in need with the population aging, with more chronic diseases, more multiple diseases, people taking multiple drugs, with a reduction in the supply of physicians? And it's clear that AI is one of the tools that we have to be more efficient in using the physicians and processing the data. You can see here some of the many sources of data. And when you look at things like vital signs, that could be coming from your visit to your physician office, but it could also be coming from your Apple Watch. So we have many more places where data can be coming. The ability to look at all this data in fewer and fewer minutes with fewer physicians, it's just overwhelming. So scaling is a huge need, a huge opportunity. One of the companies that set out a decade or more ago to try to deal with this huge influx of data was IBM in building their Watson system. Now, I particularly remember Watson because I'm a huge Jeopardy fan. And back about 10 years or so ago, Watson was put up against the best Jeopardy players in the world and was able to defeat them, was faster at accessing data and being able to get to sometimes pretty obscure facts to answer these Jeopardy questions. But IBM didn't develop Watson so that it could play Jeopardy. IBM developed Watson as a health platform, and they saw this as a huge business for them. I'm trying to remember the numbers. I think they invested something like $7 billion in building Watson Health. And this was supposed to be a huge new business opportunity for IBM. Some of you may recognize that in the last few months, there's been a lot of information about Watson in the news, and Watson was sold, the Watson technology was sold literally for pennies on the dollar. And most of that was for data as opposed to technology infrastructure. And why did this fail? Well, there are a number of reasons. Doctors cited the complexity of patient files, that Watson really wasn't trained appropriately in dealing with the complexity of patient data from all the different sources. There was a lack of real world data, a lot of training of data sets based on hypotheticals and based on clinical trials, which in many cases weren't representative of the population. So until the last decade or so, the FDA didn't require female participation in clinical trials, for example. This gets back to some of the needs that Karen highlighted when she talked about women's health and many of the opportunities that are now in front of us in the women's health space. So a lot of the older data that talks about diagnosis, that talks about medication use and effect, were done on predominantly male populations and often white male populations. So you try to apply that data without the knowledge of the patient sitting in front of you, and you get garbage. So the Watson Health system was a bust. It basically, again, was sold for parts. It shows how much care needs to be put into artificial intelligence in order to scale it for population use. There's so many factors that need to be taken into account to make this really viable. Karen, could you talk about some of what you're seeing in terms of how you get to good outcomes using AI?
We talked about the therapeutics and monitoring and treating chronic conditions, but you talked about the shortage in clinicians that is an increasing problem, and the aging population and the data overload. So it makes treatment become more and more complicated. But as you said, it can be overcome with AI tools. So I'm going to give you a few examples for efficiency tools that can assist clinicians and the system in managing the time and providing a better care. So the first thing that AI can do in order to help the physicians is to assist them to spend less time on diagnosis and allow them to spend more time with the patient. So this is already happening in CT scans and MRI, etc. For example, there is a company named ADOC, which is a platform that scans X-rays and CTs automatically, alerts doctors, and helps radiologists to prioritize cases. Another example is Viz.ai that use AI to automatically detect strokes and triage patients directly to a stroke specialist. Another use of AI for efficiency tool is automation of clinical workflow processes that accelerate clinicians' decision making. For example, there is a company named Telehealth that operates in the background of mental health clinician-patient conversations. It records and analyzes the sessions and provides the clinicians with personalized and efficient data, to provide a better care. Another example is what I talked before about Feel Better, which can track the patient's journey, predict risks, and help in decision making for providing the best care. And there are tools for revenue and management and coding. And we invested in a company named Maverick AI, which is replacing the manual coding in an automated coding and ensures it's correct and complete and increases revenue and collection. And there are also benefit management models like platforms that through AI provide personalized projections that optimize insurance and financial plans. So AI is needed for improving both efficiency and value in healthcare. And I think you can't, it's not disconnected because they are both assisting in providing better care, safety, accuracy, and it's not the efficiency tools. They are not only they don't only save time and money, but also improve health.
Thank you.
So this is an interesting quote by Dr. Horvath from an interview last year. And I think it goes back something to what you said, Karen, with the story about Watson. What he really is saying here, AI is not going to replace physicians, but physicians who use AI are going to replace physicians who don't. And if a decade ago we thought, that we'll be in the situation of the robot or the computer will see you now, we now have better understanding of some of the complexities, some of the things that AI can do well, and some of the things that it cannot do well. And one of the issues is that the rate of medical knowledge is being advanced in exponential rate. In the 80s, it took about 7 years to double the amount of medical knowledge in the sense of publications, and it's now doubling roughly every 3 months. And once you build this system and you validate it and you use a large database, and now you try to run it for 5 years, you're not improving or you're not changing the way the system is interacting with the data, and it's not taking into account advancement of the years that happened after it was deployed in the market. And I think this is a very astute statement about where we need to go. We need to be able to combine the two, because some things computers do very well, but in other areas, it's a lot easier to train people to fill those gaps.
Thank you. I want to make sure we have time for some of the audience questions. So let's wrap up with a final point from each of us in terms of predictions, where we see this technology going. Karen, would you like to kick us off?
Yeah. So I'm a great believer in cure, and we are all waiting for cure, but cure is hard and it will take time. And AI is not a cure, but it definitely is an alternative for cure until cure comes. Like for my daughter, I believe that technologies keeps improving, and she will be able to live as if she is healthy in just a few years, until she get cured. So the bottom line is, I think that AI could definitely be an alternative for cure.
Great. Aran?
From my perspective, I'm a big believer in automation, but we need to think carefully about what are we going to automate. And, a non-automated example, but a good one, is we used to do with blood draw. 50 years ago, you needed a blood draw, a doctor had to do it. Then we said, well, actually a nurse can draw your blood. And later on we said, well, don't even need to be a nurse. We can train a phlebotomist and they'll draw your blood and it will work just as well. Very similar to the example that we've seen in closed loop system, in the d-Nav example, in providing insight and artificial intelligence for people that inject. We need to find more and more areas of care delivery that we can automate and delegate to software and allow the physician to supervise all of this.
Thank you. And overall, and we've talked about many of these aspects before, but for this to be accepted by doctors, by medical personnel, we need to be able to integrate into the practice of medicine. Some of the efficiency-oriented companies that Karen talked about, which make doctors' lives easier, nurses' lives easier, those will be great in terms of adoption, because most doctors don't want to do the administrative tasks. They want to get to the point of caring for patients. So really understanding the healthcare system from the inside out is critical for people who are innovating in this area. So in general, what we've seen is that there's a dire need. We have an increase in demand for treating patients, from the increased burden of chronic care, the increase of consumerization, which makes customers, patients more demanding, and the shortages of healthcare providers all mean that there's a huge role for us moving forward, for technology and for AI in particular, to play a key role. So with that, let's move on to some Q&A. There is still time to submit questions, so please use the Q&A tab on the left side of your screen. We've got a bunch of questions already, and we'll try to get to them. So let me kick off with a question here. What's the biggest obstacle to the full embrace of AI in healthcare? Maybe, Aran, you can take that one first.
Yeah, I think Karen mentioned something before that might have been overlooked, and that's the issue of trust. She mentioned how they've learned to trust the AI system, the closed loop system. I think when we delegate something to a computer, we need to feel comfortable that we can trust the computer to do its job. And then the other side of it is aligning expectations, because sometimes we think we're going to give it to a computer and it's going to be perfect, and it's hard for us to accept that it's not always going to work. So we talk, for example, about autonomous driving as a factor that would reduce car accident by about 90%. But it's very hard for us to accept 10% of accident caused by computers. So I think as a society, we will need to do two things. One is to trust computers to treat us as well and maybe better on some instances than what our providers do, and also accept the fact that it's not a perfect solution.
Absolutely. One of the things we haven't spent a lot of time talking about today is the role of the payer in all of this. And definitely a key obstacle in getting AI fully embraced is making sure that people can be adequately paid for the work. We did talk about some of the changes in being able to get payment for virtual care and having things like codes for remote patient monitoring. But we look at the payer part of the equation, and it is just a huge part of our healthcare system, from adjudicating claims, seeing if diagnostics are appropriate and should be paid for, do things need to be pre-authorized or not. There's a huge part of the payer equation where the appropriate use of AI can really smooth the way. So it's an area where we've seen some, but I believe we'll see a lot more innovation. And without those things in place, it's definitely been an obstacle. So, for example, Medicare Medicaid, I guess, doesn't currently pay for software as a medical device. So there's now a category, the FDA has a category of software as a medical device. You can get software approved and prescribed or available OTC, but it's not paid for in the same way. So until we figure out how to get payment codes in for the actual software that is acting as a medical device, providing therapeutic benefit or acting as a diagnostic, there's going to be a limitation to how broadly those things get embraced.
I totally
Karen,
agree
would you
with
like
you,
to comment?
Karen. Yeah, can you hear me? So I totally
Yes.
agree with you, and we see many startups that that having hard days getting a valid business model because of the obstacle you were talking about. But I would like to mention another point. Physicians are sometimes very hesitant about and suspicious about the AI. And we see sometimes that consumers tend to embrace these tools faster than physicians. Like we are, and especially, people with chronic disease that they want, and especially young people. So they adapt these tools very rapidly, and they sometimes, meet physicians that don't agree with them. So this could be an obstacle.
Absolutely. Lots of potential, but still a lot of work to do.
Yeah.
Okay, we have another question here about additional applications where AI can replace certain physician tasks, and which tasks specifically. Maybe, Karen, you could start with that one.
Yeah, so I talked about a few examples, and that physicians, are, all of the decision support systems that can help the physicians get the right decision in a few minutes. Like there is a company that is called the Serenus AI, that is a decision support system that help physicians decide whether a medical procedure is needed or not by AI tools. Or so this is one example. Like I saw examples of AI that assists to embryologists perform the work faster by selecting the right embryos or the right sperms for. So we can see AI is everywhere, and all the efficiency tools with all kinds that I have to emphasize that they don't replace the physician, but it helps the physician provide better care and faster care.
And I'll just add, Karen, you already mentioned when you were giving some examples, companies that are using AI in imaging. And this has been a particularly productive area for the application of AI. And I'll just mention a couple of additional things here. Mammography has moved from analog to digital for most of us over the course of the last decade or so. And there have been quite a few studies done looking at using AI to identify things that you otherwise couldn't pick out with the naked eye, and looking at the efficiency of diagnosis with an AI-driven system in the absence of a radiologist, mammographer, and in conjunction with a mammographer. And the data is quite strong, at least to this point, that the best solution comes from both. There are nuances that the human eye picks up that AI actually doesn't see all that well, and there's a lot that the computer, that the machine can pick up, machine learning can take up. So that's an interesting area. Another example, so that's an area where physicians need to work in concert with imaging. Another example, a company called Vida has FDA-approved lung biomarkers where their software can see things in the lung that allow, for example, for early diagnosis of interstitial lung disease, which is something that currently can take a very long time to appropriately diagnose. And in that case, these biomarkers are indicative of disease and are augmenting the other data that physicians are incorporating, but physicians don't need to look separately at those scans because we just can't, with our eyes, we can't see the data we need from those scans. So many examples. We have another question here about the use of diagnostics. So let me just read the question. It says, diabetes management has been benefited significantly from the involvement of AI. An area I still feel is lacking is in diagnosis and screening of chronic diseases and their complications. Do you have thoughts about earliest stages of disease management? Aran, maybe you can jump in here.
Sure, yeah. I think, of course, there's a tremendous potential. And a company like Omada that Karen mentioned before actually started from a diabetes prevention program that was digitally delivered. I think the challenge goes back to the issue of reimbursement. And there is a limited reimbursement mechanism in play for software, as you mentioned before. And there's actually a legislation in front of Congress now to introduce a new category of payment to be able to pay for prescribed digital therapeutics. And then in early stages of diseases, you know, we'd like to say that focusing on prevention is great because it's going to save us a lot of money down the road, but pain from prevention is painful because typically there's no cost associated with the patient. So if you have pre-diabetes, cost of caring for you is practically nothing. Maybe you're taking metformin, which is like $5 a month. It's hard to justify a solution that will be used in early stages and be paid for. And until we figure that part out, I think companies would be reluctant to come up for solutions where there's not a lot of money involved.
Yeah, that's excellent. And I'll just add, since diagnostics is one of my favorite topics, there are also technologies that are being developed in the acute setting for digital diagnostics, which could have a huge impact on our system. So for example, there's a company called Wavely, which is developing a phone app using the technology that's built into a cell phone that all of us have to remotely diagnose ear infections in children. Ear infections are the leading cause of pediatric visits. And right now, without a physician physically looking in the ear of a child, you can't get a visit. So you can't do a remote visit for ear infections. But if you can use this diagnostic and be able to know whether you've got fluid behind the ear, whether it's likely to be a virus versus bacterial, then you can have a remote visit and you can appropriately treat that child rather than having a screaming child who you have to, in the middle of the night, either take to an emergency room or find other way of caring for. So many of these tools can have a big impact here. Well, we're really out of time here. So let's just wrap up with a final question. And that is to summarize, because this is all about patients, some examples, again, about how AI has directly benefited patients. Aran, maybe kick us off here?
Yeah, sure. So we've been using the d-Nav technology in the UK, Northern Ireland, for nearly a decade now. And one of the things that we're seeing, we're dealing with people with advanced type 2 diabetes. Typically, they come to us, they have type 2 diabetes for 17 years. They've been using insulin for 6 years. The average mortality rate for such patients in the UK is 3.1% per year. The average mortality rate for patients in the d-Nav-driven clinic is 0.8% per year. So that's like 80% less than what we see in the standard of care. And to be very careful, I'm not arguing that d-Nav reduces mortality by 18%, but I am seeing that patients that use AI tend to do a lot better and also stay alive.
Absolutely. And Karen, to finish us off here?
Yeah, so
you've got the best example.
Yeah, I got the best example. So as I said before, I mean, the mental burden of dealing with the chronic disease. This is, I think, the most valued, benefit that I can see and I can understand. And also another point that, that the AI brings democratizations and equity in healthcare, which, these values, they're so important. So we need that as many people can be treated better and can take, their health, to their hands and get, clinical better outcomes. So I think that it summarized the role in AI in healthcare.
Thank you. Great way to wrap up. So thanks to everyone for attending this Fierce Healthcare webinar. Thanks to my fellow panelists for participating, and thanks to Hygieia for presenting today's discussion. As mentioned earlier, the webinar has been recorded, and you'll be able to see access within about 24 hours using the same audience link that you were given earlier to join this webinar. Thanks again for joining, and we look forward to seeing you at future events.
Thank you.